I'm Dr. Elizabeth Blackwell, and after 7 years of practicing medicine and following the latest cardiovascular research, I need to share something with you today that completely changed how I think about heart disease. In November 2020, the European Heart Journal published findings from a trial called EVAPORATE that showed something remarkable. Patients who took a specific type of purified omega-3 fatty acid saw their most dangerous coronary plaque actually shrink by 17% over 18 months. Meanwhile, the patients on placebo watched that same deadly plaque more than double. Let me say that again. One group experienced 17% regression. The other group saw their plaque grow by 109%. Same time period, same type of patient, same statin therapy. The difference was a single prescription medication that most cardiologists still aren't discussing with their patients. And here's what makes this urgent for you today. If you've been taking fish oil supplements from your local pharmacy or grocery store because you heard they're good for your heart, there's a very good chance you're taking the wrong kind. In fact, certain fish oil combinations have been shown in head-to-head studies to actually raise your bad cholesterol, the very thing you're trying to prevent. By the end of this video, you'll understand exactly why all fish oils are not created equal, which specific type demonstrated actual plaque regression in clinical trials, and how to have an informed conversation with your doctor about whether this therapy might be right for you. First, I'll explain why the mechanism behind this isn't about lowering triglycerides like everyone assumes. It's about something far more fundamental happening at the level of your cell membranes. Then I'll give you the specific research data, the dosing that was used in trials, and most importantly, who should absolutely not take this without careful medical supervision. If this topic affects you or someone you love, drop a comment below and let me know. I read every one. Now let me tell you about Raymond. Raymond came to see me at age 68, referred by his primary care doctor after a coronary CT angiogram showed something concerning. Raymond had been doing everything right, or so he thought. He'd been on a statin for 5 years. His LDL cholesterol had dropped from 142 to 71. His triglycerides were elevated at 237, but his doctor said the statin was handling the main problem. Raymond was also taking fish oil. 3,000 milligrams per day of a popular over-the-counter brand, EPA plus DHA, just like the label said. Good for the heart, the marketing claimed. But his CT angiogram told a different story. The radiologist noted multiple areas of low-attenuation plaque in his left anterior descending artery. Low-attenuation plaque. That's the medical term for soft, unstable plaque, the kind that ruptures, the kind that causes heart attacks. Think about the difference between an old, hardened, calcified plaque and a soft, fatty, inflamed plaque. The calcified plaque is like a stable scar. It's not good, but it's unlikely to suddenly break open. The soft plaque is like an abscess waiting to burst. It has a thin, fibrous cap covering a pool of fatty debris and inflammatory cells. When that cap ruptures, blood rushes in, forms a clot, and blocks the artery. That's what causes heart attacks. Not the hard plaques that show up on calcium scores. The soft, dangerous ones that calcium scores completely miss. Raymond had a lot of soft plaque, and despite doing everything he thought was right, it was progressing. This is what researchers call residual cardiovascular risk. You've lowered your cholesterol. You're on optimal statin therapy. Your numbers look good on paper, but you still have a significant risk of a cardiac event because statins alone don't address everything happening in your arteries. In REDUCE-IT, a massive trial published in the New England Journal of Medicine involving over 8,000 patients, researchers found that even among people on statins with well-controlled LDL cholesterol, there was still a substantial burden of cardiovascular events. Heart attacks, strokes, the need for procedures. These weren't people ignoring their health. These were patients doing what their doctors told them, and they were still having events. Comment yes below if you've ever wondered whether you're doing enough despite taking your medications. This pattern is more common than most people realize. So what's happening at the level of the artery wall that statins alone aren't addressing? This brings me to the curiosity gap I mentioned earlier. It's not primarily about triglycerides. I know that sounds counterintuitive. The prescription medication I'm going to discuss does lower triglycerides. That's actually how it got approved. But the cardiovascular benefits turned out to be much larger than the triglyceride reduction alone could explain. Let me explain the mechanism that researchers now believe is really driving the benefit. And this is where it gets fascinating. Every cell in your body has a membrane. Think of it as the outer boundary, the wall that separates the inside of the cell from the outside environment. This membrane is made of lipids, fatty substances arranged in a specific structure. And within this structure, cholesterol plays a crucial role. Under normal conditions, cholesterol is distributed evenly throughout the membrane, keeping it flexible and functional. But under conditions of inflammation and oxidative stress, something problematic happens. The cholesterol starts aggregating, clumping together, forming what scientists call cholesterol crystalline domains. Think of it like ice crystals forming in water. When conditions change, the previously dissolved substance starts solidifying into distinct structures. When cholesterol crystals form within the plaques in your arteries, they act like tiny shards of glass. They trigger inflammation. They destabilize the plaque. They make that thin, fibrous cap more likely to rupture. This is one of the mechanisms behind vulnerable plaque formation. It's not just about how much plaque you have. It's about what kind of plaque it is and how likely it is to rupture. Now here's where the difference between types of omega-3 fatty acids becomes critical. EPA, icosapent acid, and DHA, docosahexaenoic acid, are both omega-3 fatty acids. They both lower triglycerides. They both get incorporated into cell membranes. But at the molecular level, they behave very differently. EPA has a 20-carbon chain with 5 double bonds. DHA has a 22-carbon chain with 6 double bonds. Those 2 extra carbons and that additional double bond completely change how the molecule interacts with the cell membrane. Biophysical research published in journals like Chemistry and Physics of Lipids has shown that EPA inserts into the membrane in an extended, relatively rigid conformation. It distributes itself evenly throughout both the ordered and disordered regions of the membrane. This helps keep cholesterol evenly distributed rather than allowing it to clump. DHA, with its longer chain and additional double bond, is more flexible. It tends to exclude itself from the ordered regions of the membrane, and in doing so, it actually promotes the formation of cholesterol-rich domains, the very thing we're trying to prevent. Let me be clear, DHA has benefits. It's important for brain health, for eye health, for fetal development. I'm not saying DHA is bad, but when it comes to stabilizing arterial plaque and preventing cholesterol crystallization in your blood vessel walls, the research suggests EPA may be the better choice. A 2018 study in the Journal of Clinical Endocrinology and Metabolism, comparing high-dose EPA to high-dose DHA, found that DHA increased LDL cholesterol by about 8%, while EPA had a neutral or slightly favorable effect. Both lowered triglycerides. But DHA raised the very thing we're trying to lower for heart protection. This is why your grocery store fish oil might not be helping and could potentially be hurting your cardiovascular goals. Most over-the-counter fish oil supplements contain a mixture of EPA and DHA, often with more DHA than EPA. The typical ratio in many supplements is roughly 60% EPA to 40% DHA, or sometimes even less EPA than that. Now here's what the research showed with pure EPA. The REDUCE-IT trial used a highly purified form of EPA called Icosapent Ethyl, sold under the brand name Vascepa, 4 grams per day. That's significantly higher than what most people take from supplements. The results were remarkable. A 25% reduction in major cardiovascular events, a 20% reduction in cardiovascular death, a 30% reduction in total cardiovascular events when counting first and subsequent events together. The New England Journal of Medicine published these findings in 2019, and they sent shockwaves through the cardiology community. This was not a marginal benefit. This was a major reduction in events that matter: heart attacks, strokes, death. But here's what I want you to understand. The triglyceride lowering was only about 18%. Previous trials of triglyceride-lowering drugs that achieved similar or even better triglyceride reductions showed no benefit on cardiovascular outcomes. So the benefit couldn't be explained by triglyceride lowering alone. That's why researchers conducted the EVAPORATE trial as a companion study. They wanted to actually look at what was happening to the plaque itself. EVAPORATE enrolled 80 patients with coronary atherosclerosis, who were already on statins with elevated triglycerides. Half received Icosapent Ethyl 4 grams daily, half received placebo. Both groups underwent coronary CT angiography at baseline, 9 months and 18 months. The primary endpoint was change in low-attenuation plaque volume, that dangerous, vulnerable, rupture-prone soft plaque. Here's what happened. In the Icosapent Ethyl group, low-attenuation plaque volume decreased by 17%. In the placebo group, it increased by 109%. Statistical significance was achieved with a p-value of 0.0061. But it wasn't just low-attenuation plaque. Fibrous plaque regressed in the treatment group and progressed in placebo. Fibrofatty plaque regressed in the treatment group and progressed in placebo. Total plaque burden improved in the treatment group. This is actual plaque regression, not just slowing progression, reversal. The EVAPORATE trial was published in the European Heart Journal in 2020, and it provided the mechanistic evidence that helps explain the clinical outcomes seen in REDUCE-IT. High-dose pure EPA stabilizes and shrinks vulnerable plaque, and that translates to fewer heart attacks and strokes. I want to be very clear about what this does and does not mean. This does not mean you can throw away your statin. In both REDUCE-IT and EVAPORATE, patients were on statin therapy. The benefits of Icosapent Ethyl were additive. They came on top of the benefits from statins, not instead of them. This does not mean that Icosapent Ethyl reverses all heart disease or guarantees you won't have a cardiac event. It significantly reduces risk. It doesn't eliminate it. This does not mean that over-the-counter fish oil at typical doses will achieve these results. The dose matters. The purity matters. The formulation matters. And the EPA only versus EPA DHA composition matters. Always discuss changes with your healthcare provider. This information is designed to help you have a more informed conversation with your doctor, not to replace their guidance. Now let me tell you about someone who didn't have that conversation first. Vernon was 74 and had been in atrial fibrillation for 2 years. His cardiologist had him well controlled on rate and rhythm medications, and he was taking Warfarin, a blood thinner, to prevent stroke. Vernon had heard about the benefits of fish oil for the heart. He started taking high-dose omega-3 supplements on his own without telling his doctor. He figured if some was good, more must be better. 3 weeks later, Vernon noticed unusual bruising on his arms. Then he had bleeding gums when he brushed his teeth. Then dark, tarry stools that indicated bleeding in his digestive tract. He ended up in the emergency room with an INR, the blood clotting measurement for warfarin patients, of 7.2. Normal is around 2 to 3 for people on warfarin. 7.2 meant his blood was dangerously thin, barely able to clot. The omega-3 fatty acids had enhanced the effect of his warfarin in a way that pushed him into a dangerous bleeding risk zone. Here is who should be extremely cautious or avoid high-dose omega-3 supplementation without direct physician supervision. Anyone on warfarin or Coumadin. Omega-3s affect platelet function and can enhance the anticoagulant effect. This doesn't mean people on warfarin can never take omega-3s, but it requires careful monitoring and dose adjustment. Anyone with a history of bleeding disorders or recent major surgery. Anyone on multiple blood-thinning medications. Anyone with a history of atrial fibrillation needs to have a careful conversation with their cardiologist. In REDUCE-IT, there was a small but statistically significant increase in hospitalizations for atrial fibrillation in the Icosapent Ethyl group, 3.1% versus 2.1% in placebo. For most patients, the cardiovascular benefits outweighed this risk. But if you already have AFib, your doctor needs to weigh this carefully. Anyone with severe kidney disease should consult a nephrologist before starting high-dose omega-3 therapy. This is not a medication to start on your own. This requires a prescription for a reason. The dose used in clinical trials, 4 grams per day of Icosapent Ethyl, is a pharmaceutical dose that requires medical oversight. Comment understood below if this safety information is making sense. I want to make sure this critical point isn't missed. Now let me tell you about Barbara. Barbara was 67 when she came to see me, terrified after her husband had a massive heart attack. She wanted to know what she could do to avoid the same fate. Her own coronary CT angiogram showed early plaque formation, including some concerning low-attenuation plaque in her right coronary artery. Her triglycerides were moderately elevated at 218 despite statin therapy. Her LDL was controlled at 68. She was doing everything right in terms of diet and exercise. We had a long conversation about her options. I explained the REDUCE-IT data, the EVAPORATE findings, the mechanism of EPA versus DHA. I explained that this was prescription therapy that would need to be added to her regimen, not instead of her statin. She talked to her primary care doctor and her cardiologist. They agreed it was reasonable to try. She started Icosapent Ethyl at 4 grams daily. 18 months later, we repeated her coronary CT angiogram. Her total plaque burden had decreased slightly. More importantly, the low-attenuation plaque in her right coronary artery had not progressed. Her cardiologist called it stable. Given what we know about how quickly vulnerable plaque can progress, stable was a very good outcome. Barbara didn't experience plaque regression like some of the EVAPORATE participants. But she also didn't experience the doubling of dangerous plaque seen in the placebo group. For her, stabilization meant she was no longer watching a ticking time bomb grow. I share this story because I want to be honest with you. Not everyone will see dramatic regression. The 17% improvement was an average across the study. Some patients did better. Some did not improve as much. But on average, the treatment group went in the right direction, while the placebo group went in the wrong direction. Realistic expectations matter. This isn't Drano for your arteries. It's not going to melt away years of plaque accumulation overnight. But it may slow or stop progression. It may stabilize vulnerable plaques. And over time, it may contribute to measurable improvement. The timeline matters too. EVAPORATE showed effects at both 9 months and 18 months. This is not a medication that works in weeks. It works over many months to years. Sustained benefit requires sustained treatment. Here is what the protocol looked like in the clinical trials. Patients were already on maximally tolerated statin therapy. This is not instead of statins. It's in addition to statins. Patients had elevated triglycerides, typically above 150 milligrams per deciliter, as that's the population that was studied. The dose was 4 grams per day of Icosapent Ethyl, taken as 2 grams twice daily with meals. The medication is better absorbed with food. Treatment was continued long-term. In REDUCE-IT, the median follow-up was nearly 5 years. If you're interested in whether this might be appropriate for you, here are the questions to discuss with your doctor. First, what are my current triglyceride levels, and have they been checked recently? Second, am I on optimal statin therapy, or is there room for improvement there first? Third, do I have any contraindications to high-dose omega-3 therapy, such as atrial fibrillation, bleeding disorders, or medications that interact? Fourth, would it be appropriate to get a coronary CT angiogram to assess my current plaque burden and composition? Fifth, if we start this therapy, how will we monitor its effects and any potential side effects? If you're a Pure Longevity VIP member, you'll receive a printable large font checklist with all these questions and the key talking points from today's video that you can bring directly to your doctor's appointment. It also includes a summary of the trial data. If you're not a member yet, the link is in the description. And the insider level gives you early warnings about health scams and social security changes that affect seniors. Now let me address some of the skepticism you may encounter. Your doctor may not be familiar with EVAPORATE. The trial was published in 2020 and received less attention than REDUCE-IT because it was an imaging study rather than a clinical outcomes trial. Many busy physicians haven't had time to review this data. Your doctor may be cautious about prescription omega-3s because of previous studies that showed no benefit. And those concerns are legitimate. Multiple large trials of standard fish oil supplementation showed no cardiovascular benefit. Vital, Ascend, OMEMI, Strength. These trials used either low doses, mixed EPA and DHA formulations, or populations that may not have needed additional therapy. The difference with REDUCE-IT and EVAPORATE was the use of high-dose, highly purified EPA alone at 4 grams per day in patients with elevated triglycerides despite statin therapy. This is a different therapy used in a different population. Your doctor's caution is actually a sign of thoughtfulness. They're not dismissing you. They're applying appropriate scientific skepticism. But the evidence for this specific formulation at this specific dose in this specific population is robust. The European Society of Cardiology, the American Heart Association, and other major cardiology organizations have incorporated Icosapent Ethyl into their guidelines for patients with elevated triglycerides and established cardiovascular disease or diabetes. Comment. Talking to my doctor below if you're planning to bring this up at your next appointment. I want to see how many of you are taking action with this information. Let me come back to Raymond. After our conversation about his CT findings and the emerging research on pure EPA therapy, Raymond talked to his cardiologist. Given his elevated triglycerides and the concerning plaque findings, his cardiologist agreed to start Icosapent Ethyl. Raymond stopped his over-the-counter fish oil. He started the prescription therapy at 4 grams daily. He also made additional lifestyle modifications, including reducing refined carbohydrates, which can contribute to elevated triglycerides. 12 months later, his triglycerides had dropped from 237 to 161. More importantly, a follow-up CT scan showed his low-attenuation plaque burden had stabilized. No progression. Given what we typically see in placebo-treated patients, where that plaque can more than double in 18 months, stabilization was a significant win. Raymond told me he feels more in control. He understands his disease better. He's working with his medical team rather than just hoping his supplements are doing something. That's what I want for you too. Understanding, agency, partnership with your healthcare providers. I'm not here to tell you that there's one magic solution to prevent heart disease. There isn't. Cardiovascular disease is complex. It involves genetics, lifestyle, inflammation, metabolism, and many other factors. But I am here to tell you that the science has evolved. We know things now that we didn't know 5 years ago. We have tools now that we didn't have before. And when high-level evidence from randomized controlled trials shows a 25% reduction in cardiovascular events and actual regression of dangerous plaque, that's worth talking about. Your grocery store fish oil is probably not doing what you think it's doing. If you're taking it for heart protection, the evidence simply doesn't support standard mixed EPA-DHA formulations at typical doses for that purpose. If you have established cardiovascular disease or diabetes with elevated triglycerides despite statin therapy, there is now a proven option that may provide additional protection. But it requires a prescription, medical supervision, and a conversation with your doctor. Your heart has been beating for you every single day of your life. It deserves attention. It deserves the latest evidence. And you deserve a healthcare provider who will look at this data with you and help you make the best decision for your specific situation. If you found this video valuable, please share it with someone you love who needs to hear this. Subscribe to the channel and click the notification bell so you don't miss our next deep dive into evidence-based heart protection. And comment below with your biggest takeaway from today's video. I want to know what resonated with you. Until next time, this is Dr. Elizabeth Blackwell, reminding you that knowledge is power when it comes to your health. The more you understand, the better conversations you can have with your medical team, and the better outcomes you can achieve together. Take care of your heart. It's the only one you've got.